So today we're going to be talking about genital tuberculosis or genital TB. So it is an infection of genital tract by the Mycobacterium tuberculosis, the causative agent of TB, okay? So how does it happen? So most commonly it is going to be a secondary infection, which means first of all your lungs are going to get affected, okay, you're going to have pulmonary TB, and most commonly via the hematogenous spread via your blood vessels, okay, is going to travel through blood and is going to reach your female genital system, okay? And it can also travel via lymphatics, or there can also be a direct spread, which is actually pretty rare. So most commonly, the fallopian tubes will be affected first of all, and in mild to moderate disease, there's going to be tuberculous exosalpingitis, okay? So it's going to look like a tobacco pouch, so we call it a tobacco pouch appearance, okay? As you guys can see, it looks like a tobacco pouch, okay? In moderate to severe disease, it's going to be shaped like a retort, okay? Retort is actually like something that chemists or like the scientists or whatever you want to call them, okay, they use it. It's like a flask, okay? And so this is how it looks like, right? So the uterus is the second most common part to be involved, okay? So it's going to cause tuberculous endometritis, okay? So in this, there are going to be caseating granulomas if you do the histopathology of the endometrium. So as you guys can see, clear-cut caseating granulomas are seen. And then the cervix is usually not going to show any gross changes. And if you do microscopy, if you do the histopathology of the cervix, you're going to see some granulomas in it, okay? The vulva or vagina, it is the rarest part to be involved when it comes to genital TB, and you're going to see hypertrophy of the vulva, okay? Now this hypertrophy kind of resembles elephantiasis, so as a doctor you got to rule out elephantiasis when you see this, right? So the clinical features, since the fallopian tubes are most commonly going to be involved, so there's going to be blockage, so the patient is going to complain of not being able to have babies, and there are going to be menstrual disturbances like amenorrhea, menorrhagia. There's going to be pain associated with it, so it's going to be abdominal pain, vaginal discharge may be there, abdominal mass may be palpable, okay? The investigations, you're going to do the CBC, you're going to get lymphocytosis, of course, and then on ESR, since inflammatory conditions, so it's going to be raised. Mentox test, positive, since TB, right? And then we have hysterosalpingography. It's going to show beaded tubes, okay? It's going to show a beaded appearance. As you guys can see, this is the beaded appearance of the fallopian tubes, okay? Then on the endometrial histopathology, you're going to see caseating granulomas, as I showed you earlier. ELISA and PCR, they can be done to detect the bacteria's DNA. Chest X-ray can be done to check if the patient still has pulmonary TB. So these are the differentials that you're supposed to rule out. Pelvic inflammatory disease, since the patient is going to present with infertility, you got to rule out PID. You got to rule out pregnancy, you got to rule out ectopic pregnancy, and also CA cervix, since the condition kind of mimics that, and then also elephantiasis of vulva, since I showed you earlier, it kind of looks like it. For the treatment, you're going to use the anti-tubercular therapy, anti-TB therapy, okay, you know all these drugs. And the surgical treatment, okay, it's usually avoided unless complications arise like pyrosalpinx is there, or there's no resolution of symptoms with anti-tubercular therapy. So this is all with genital TB. And thank you for watching.